So good morning, and thank you, Jonathan, for not going on and on and on. I missed the teleconference where I could pick a talk, and I was instead given something that nobody wants to talk about, which is the diagnosis of HFpEF. So thank you very much to the organizers for having me and giving me this talk. I'm also a bit of a warm-up speaker because we have two excellent speakers right after me. I'm what you call the, to make everybody else look good. So Dr. McMurray will be up next, so that's why I'm here. These are my conflicts of interest in relations with anybody. I work for anybody that has a sticker that basically I can put on a label, so that's good. We work a lot with government as well, also that's another conflict. I'm also was the chair of the guidelines, so anything you dislike about them, I can take the full heat. If you like them, then I'll compliment Eileen, who is my co-chair. So HFpEF is challenging, kind of an audience at a heart failure conference on a Saturday. You probably know that already. So everything I'm going to say today is, there's nothing new, but I'll give a bit of a different and controversial perspective. Some of you will disagree with me, and I hope you do, and then actually ask questions about it. So this is the challenge. It's a multiple phenotype type of syndrome. The trial designs are complicated because of that. There's very few clear criteria for diagnosis. The patient demographics are complex. We've kind of seen talks about that already. And there's lots of comorbidities. So by a show of hands, we're going to do this in a slightly different way. And I will just remind you that I almost lost a debate to Peter Liu because he showed a kitten about 4 years ago, and I will not ever make that mistake again. So hands up if you prefer cats versus dog. Cats, hands up. Okay, people that prefer dogs. All right, interesting, okay. So 2/3 to dogs. Okay, coffee, who prefers coffee over tea? Coffee and tea. Okay, this has direct relevance to the talk. You'll see why. Honestly, it does. So the definitions, what is HFpEF? So here's what the complicated part is. We've changed the name, which makes people confused. So there's two circles here, they're overlap, and many patients don't fall in one bucket or the other clearly. There's many diagnostic criteria that I've shown here in the circles, and that's all about ejection fraction, but we have to remember patients with heart failure are a patient and they have a syndrome, and then the ejection fraction just forms part of this. So what we've done is we've kind of made it simpler and said, well, there's only really 2 or 3 buckets depending on the guideline you follow. HFrEF, HFpEF, and then HF mid-range EF, which people like to abbreviate and make it HFmrEF, and it's hard to say. But we've taken away 2 terms which I think are really important. We've taken away the term diastolic heart failure, because that indicates that only echocardiographic or MRI-based diastolic function is important, and we know that that is not true. So we've taken away that term just to make it clearer. We've also taken away the term preserved systolic function because it is not preserved if you look at either regional wall motion abnormalities or overall preserved systolic function. It's not always as preserved as you think once you get more high fidelity imaging. So those 2 terms are now gone, so you can eliminate them. So here's it just put down in a slightly different way. We've also in the guidelines introduced something called recovered EF. It's a term known to clinicians, but it's a term that we've introduced to say this is actually not as simple as HFrEF or HFpEF. You have to identify that they've had a tremendous improvement. The challenge with HFpEF is it's both causation, association, and any other words with ION in them, because in the middle you have HFpEF, the patient right in front of you, then you have some mechanistic things around that middle circle, but the diseases you recognize in clinical practice are on the outer circle: diabetes, arrhythmias, hypertension, ischemia, etc. But you can think through the mechanisms all you want, but ultimately you have to treat one of those outlying comorbidities and see if they improve, and then kind of try to get back to the circle and say, well, maybe I can change that mechanism. So it's a bit of a challenge to where do you start? Do you start in the middle with the patient? Do you start on the outside with the comorbidities? So generally ruling out and treating the things that are listed on the side is important. An impossible to read slide, but this is to highlight that this is a terrific review by Rob Mentz and Jack 2014. And what it does in the left column puts down the comorbidities that are very common around the world in patients with HFrEF or HFpEF. And on the far right-hand side, it says, how does it actually affect each HFrEF or HFpEF cohort? And in the middle, it gives you the bidirectional impact of each one of those elements. So you can see for COPD or anemia or diabetes, it goes both ways. And so if you remember this part, that it is actually traveling both ways to affect the patient population, you can actually get to some understanding of the disease state. So I would encourage you to read this on your own. I won't go through and read this line by line for you, but just identify that these are the key comorbidities. That's the mechanisms of action by which they might affect the cohorts bidirectionally. So here's why I had you talk about dogs and cats and coffee and tea. I vote for dogs and coffee, but that puts me in group A over there. So it's a nice study published about 2 or 3 years ago, and it took data from iPreserve and CHARM. So READY trials enrolling patients with HFpEF by whatever definition, so you have to use that caveat here. And what it tried to do is put people into, using cluster analysis, put people into 6 different buckets of the phenotype of which they look like. And the idea here is to say, well, maybe it is a broad phenotype, but maybe we can identify some phenotypes we could go forward with. So here's the group, class, the group A on the far left is 100% men, 65 years old, and they have very low rates of AFib, renal disease, and valvular disease. But if you look all the way on the right, it's mostly women, 82 years old, lower BMI, they have AFib, valvular disease, et cetera. But the things that are not different across these groups, blood pressure, BNP, symptoms. Those things don't seem to matter as much for differentiating groups, but what does matter is their comorbidities, ages, genders. And so I've flippantly put dogs and coffee together and cats and tea together. You can read into that whatever you want, but we know who you are if you have cats and drink a lot of tea. But this tells you that subtypes and clusters are really complicated. So think carefully before you say, that's not HFpEF, or I only think HFpEF is this. It's a lot of different things. Our guidelines came up and said, actually, heart failure is a syndrome, so you can do whatever you want with the ejection fraction determination, but it's a syndrome. Use our algorithm. You've seen this before. In case you think we're crazy, the Europeans also agree with us, and they've said the same thing. They just use slightly different BNP or NT-proBNP cutoffs, but we're as crazy as Europeans or not as crazy as Europeans either way. So this is just put that in text to say that symptoms, signs, EF, and natriuretic peptides. That is the way you diagnose it. Beyond that, you don't need to do anything if you're outside of Canada. You have to follow something different, which is the ESC guidelines. So the ESC has taken a slightly different approach, saying symptoms, signs, EF, and natriuretic peptides. Plus, you need to have objective evidence. So they've taken the step that we decided not to take because the evidence does not support it, which is you need to have an objective, like usually an echocardiographic finding, such as left atrial volume index, left ventricular hypertrophy, et cetera, to say that that's a functional or structural abnormality. That is one approach, and it's slightly an older approach, but I think that's why I'm being provocative, because one of the former chairs of the guidelines is speaking after me, so he will disagree with me, and that's great. But they did have something nicely in that, which is they said in cases of uncertainty, so these are the patients where you really are still uncertain, use a provocative test. And so for many of us, we do not do provocative stress tests on our patients with HFpEF. It's not the thing we have been thinking about. So I'm just going to walk you through that. Before I do that, in Alberta Heart, an Alberta-based cohort that Jonathan's also involved with, we actually tested the ESC criteria to test the sensitivity and specificity. This is a broad range of patients across stage A through D of heart failure, HFrEF, HFpEF, at risk, et cetera. They're highly specific, so that's pretty good, 89% specific, and likelihood ratio is pretty good at 4.8. So the ESC criteria is pretty good, and it turns out the CCS criteria are also pretty good, but they're very insensitive. So don't think that you're going to pick up a lot of patients in terms of sensitivity here, but they're highly specific, and that's pretty good. The BNP, does it help for diagnosis? This comes up fair number of times. It generally does, but just remember it varies across the EFs, but it doesn't dramatically drop in HFpEF. It doesn't. It's a continuous variable that is elevated in patients with myocardial dysfunction. The diastolic stress test, which I was asked to make sure we cover, this is by echo or exercise, using an exercise, usually a bike. I know Jonathan does it with an invasive way, but there are non-invasive ways to do it. It measures things like E over E prime, pulmonary pressures, strain rates, stroke volumes. There are invasive ways of which some cath labs will do. I mean, that's a bridge too far for almost every patient, but just thinking through that you can do this. People have actually studied this. You know it's being studied enough when there's a systematic review about it, which there is. I'm not going to show you that, but it kind of summarizes some of these findings, which are patients with HFpEF, in general, an exercise diastolic stress test does identify those patients with a cause of dyspnea in terms of it puts them either in a bucket of HFpEF or non-cardiac dyspnea. And that's actually quite helpful, but I'll show you on the next slide why that is. And just focus on the yellow highlighted parts. On the y-axis, you see the wedge pressure, or E over E prime. If you value E over E prime, maybe it's worthless, maybe it's not. But on the x-axis, you see a rest, then increasing amounts of exercise. You see that in patients with HFpEF, they start not only with a higher LV-EDP or EOV prime, but then it also ramps up over exercise. And that's a critical pace, is as they're exercising, they're replicating the phenotype that they may have when they're walking across their house. And in patients with non-cardiac dyspnea, nothing changes. It really is a minimal change over time. It's a nice study done, published in Circ just last year, and you can walk yourself through it. But the summary is you can separate non-cardiac dyspnea from HFpEF using a provocative test, and often with echo and exercise. Then the question is, okay, we've gone through the diagnosis, now you have to ask why. And this is important because if you're going to just say patients have heart failure, you better ask why. This is a picture because I also ask, why would you do that to a car? But, you know, I can't speak for what Jonathan drives, but this is his choice. So when you're asking why, just make sure you go through our guidelines. We came up with this etiology diagram. It may look like a spaghetti diagram, but it's to help people think through what are the common causes, which is the red boxes or magenta, or there's probably some fancy name for that color. But also then think through the uncommon causes, which are things that are less common or prevalent in our clinics. So when you think about that, the ESC also has another kind of web table, which puts a lot of these other types of tests, like are you going to really test for a Borrelia in most patients? Well, I might, because we're surrounded by farmland and a lot of cows, but you're not going to test for Chagas in most patients in Alberta. So just think through that. You know, the history will drive a lot of that determination. So just the top 5 things for the diagnosis of HFpEF, what I was actually asked to talk about. These are the things I think you can take home are a rest echocardiographic finding does not equal the heart failure syndrome. It just is another echo finding. So just be careful about over-labeling people just based on an echo finding. And number 2 is that an elevated RVSP, pulmonary pressures, left atrial volume index, and LVH lean towards HFpEF. They can be supportive of, but not diagnostic of HFpEF. Rule out coronary disease in all patients. That's usually underdiagnosed. Consider a provocative test. I think that's something we should probably consider. And then don't forget to ask why they have HFpEF. Do they have an underlying etiology that makes sense? So this is a summary of saying it in a slightly different way. The only additional thing is to say it's a complicated phenotype, evaluate the comorbidity, and you'll be much more smarter on Monday when you go back to clinical practice. And so I'm happy to take some time for questions at the end or now, whichever you prefer.